Oh, there's a little pop-up box. Got it. Now I should be able to move. We're all the way in the middle. Andy's online.
Hi, Omar. And how would you prefer to answer the questions or during your talk? I know it's hard to see hands going, there's little yellow hands going up in the boxes. I can monitor that if you want me to, or do you want to save time at the end? Any way that works for you.
Why don't we save time at the end? Because we're tag teaming, it's hard to say, how much time we've got. So
Yeah, and we can always kind of trim towards the end if we were running out of time for appropriate discussion. I'm kind of trimming my section towards the end.
yeah.
That sounds good.
And is there a specific location that we should talk towards that the audio would pick up better?
That's our camera.
Yes, camera and microphone.
Yeah, the microphones are all over.
Okay.
Great, but when you feel like looking at the folks, there they are. At the camera.
Give you some bodies, make it more organic.
That's a great idea, Omar.
So I guess the others.
Okay.
All right then. Well, I want to welcome you to the second in our Dworak-Peck School of Social Work Colloquia series. And today we are delighted to present our colleagues, Dr. Erika Garcia from the Department of Population and Public Health Sciences in the Keck School of Medicine, and Dr. Palinkas of the Dworak-Peck School of Social Work. And they will be speaking today on an extremely critical topic of climate change and health equity. And I would like to request that you hold your questions for the end, if you can, and we will allot some time specifically for interaction with our speakers. So thank you. Welcome to our speakers. Take it away.
Well, thank you very much, Suzanne. It's a pleasure to be with you all today to talk about work that we have been spending the last year and a half now working on together through a mechanism funded through the USC Office of Research that provided an opportunity to bring faculty from different academic units within the university together. The focus of the work that we have been doing is on climate change and health equity. And for those of you who know me, much of that work rises out of my involvement as co-lead for the Social Work Grand Challenge and creating social responses to a changing environment. Erika, who is an environmental epidemiologist, has been focused on very similar issues, but from a slightly different perspective. The one thing that the two of us have in common, as well as our colleagues, both here in social work, as well as in population public health sciences, has been an interest in environmental and social justice. So I want to begin by talking about things that most of you are probably all familiar with, and if you're not, you should very much be involved in gaining more information and insight on the issue, and that is climate change. As you probably know, if not experienced personally, the world is becoming warmer, largely due to human activity that creates warming of the planet, release of carbon dioxide and other chemicals into the atmosphere that has projected to increase the temperature around the world to an average between 1.5 and 5.8 degrees centigrade. And those figures change constantly depending upon the extent to which nations around the world are able to enact programs to mitigate human activity and its impact on the climate. We've seen this evidenced in many forms around the world. In some parts of the world, it is becoming a little too wet. In other parts of the world, a little too dry. And in some regions, you begin to see both phenomena occurring, such as in the Pacific, where the prolonged drought has resulted in bushfires in places like Australia, or lack of fresh water in island nations like Tuvalu. Or in addition to increased frequency of hurricanes, typhoons, and cyclones, and the flooding and sea level rise that has been associated with that. In many parts of the world throughout the Pacific and the Caribbean, island nations are under threat of disappearing as a result of climate change. And the events of prolonged flooding and sea level rise is likely to impact the availability of land mass, as well as increased expenses in building infrastructure to prevent further damage due to hurricanes and other extreme weather events. Among the many impacts of climate change has been a decline in economic activity, particularly on land through agriculture and on sea through harvesting of marine resources. It's also led to increased civil conflict. The war in Syria, for example, was a direct result of, among other things, a prolonged drought in the eastern part of the country in 2012, 2013. It's also led to widespread displacement of the population, not only in response to extreme weather events such as hurricanes like Katrina, but to prolonged erosion of areas where Native Alaskan, Native American communities in the United States, indigenous communities elsewhere have been severely impacted. Above all, climate change is a social justice issue because women, children, older adults, the disadvantaged residents living in both urban areas as well as rural areas, and those with a history of mental illness are probably the most vulnerable to climate change because of the greater exposure to extreme weather events and longer term impacts on climate, and greater vulnerability to this exposure as well. In order to address this on a more local level, colleagues from the Suzanne Dworak School of Social Work and the Keck School of Medicine decided to collaborate in submitting an application to the USC Strategic Directions and Research Award, which is funded by the Office of Research Administration and Support. It was intended to leverage unique strengths within UCSD through collaborations across 3 schools, Keck, Social Work, and the Viterbi School of Engineering, in a way of promoting environmental justice by focusing on the co-occurring effects of 2 particular forms or 2 particular impacts of climate change: prolonged heat waves and more frequent and severe forms of days of poor air quality due to air pollution. We intended to do this by adopting innovative methods to estimate heat and air pollution exposure in Southern California, as well as ethnographic and other qualitative methods to assess how communities who are most vulnerable to this combination of heat and air pollution have been adapting to these increased frequency of combined events. The 2 types of studies we're going to describe today are both epidemiologic in nature and qualitative in nature. As leader of the epidemiologic studies, I'm going to turn it over to Erika to describe some of the things that we've been working on, some of the findings that we've gained to date. Erika.
Thank you, Larry. And just a comment before I start, the climate change is very, very complex. And I think the bridging together of folks from different disciplines to be able to tackle the research questions from different angles and to have more synergistic and also better research at the end of the day is critical. And I think this research that we've compiled the last year and a half or so with our colleagues is indicative of the approach that we need to take in order to do better science and improve public health and improve the lives of people as we go through changing climate. Okay, so our specific aims for the epidemiologic portion of this analysis was to look at the co-exposure of heat and air pollution. So we know air pollution and heat are both related to increased mortality. And with climate change, we're going to have greater exposure to heat, greater exposure to air pollution, both average levels and these extremes. And their relationship is co-occurs. You can imagine when it's really hot, there's also red flag warnings here. You have wildfires that also really increases air pollution. And so our specific aim here was to examine the effect of this co-exposure to air pollution and heat on respiratory, cardiovascular, suicide, homicide, and all-cause mortality. And we wanted to look at how these relationships might be different by different local factors like availability of air conditioning, some aspects of the environment, and social economic status. So we used mortality data. So this is death certificate data from the state of California. You can see the dates there from 2014 through 2019. So right before the beginning of the pandemic, we're looking at daily, so short-term exposure and recent exposure to temperature and air pollution levels. This is based on the decedent's residential census tract, so where they were reported living on their death certificates. And the study design that we used here is what's referred to as a time stratified case crossover study. And get the mouse here. And what it does, so let's say that the person died on the 26th of July, 2018. This is a Thursday. All other Thursdays in that month that they did not die, or all other Thursdays in that month, would serve as the control periods for that person. And what's really nice about this design is every case or every decedent serves as their own control. So we are controlling for a time invariant factors, or factors that do not vary over time, at least within that 1 month time frame. So you can think about things like lifestyle factors, social economic status, health status, and such. So this is a really great design. So case crossover, and we used some statistics conditional logistic regression models to analyze this. So for our exposures, as we said, we're interested in extremes. And so how do we define extremes here? We actually used a percentile-based threshold method. So you can see we did a couple of different, here we are, thresholds, 90th, 95th, 97th, 99th. And we had these cut points based on different distributions. For the extreme heat, because there's some adaptation possibility with heat, it was for the distributions within our time period that was specific to the census tract that a person resided in. So the 99th percentile for that census tract over this time period. Whereas for pollution, which we're using the fine particulate matter, it's going to be for the entire California, for the entire state, because we don't believe there'll be adaptation to pollution, even though you might live in a more polluted area. And then we defined exposure as either being extreme to 1, so either PM 2.5 or temperature, or both. So here you can see this third example, so extreme exposure to both or neither, right? That was our reference group. There's a lot on this graph, so we're just going to focus here. So we did a couple of different percentiles. You can see that, here we go, going across the left, so the most extremes towards the bottom, and the different columns represent the extreme temperature only, extreme pollution only, and both temperature and extreme days. And you can see here is this excess risk measure on the bottom. The lags just refer to whether we looked at same day, day prior, 2 days prior, et cetera, down. And so here for the 99th percentile of definition of extreme, on a day that had extreme temperature only, there was an increased risk of mortality of 5.2, confidence intervals around that. Extreme pollution was 4.0, same day, but when you had extreme to both, it was 17, which is more than the sum of their individual parts. And we saw this consistently with the different percentile measures. So you can see the strength of the association goes higher as we increase our definitions of extreme. So at the 90th percentile here with both of them, it goes 5.4, then it goes to 8.5, and then 11.7, as you kind of increase these more extreme definitions of extreme exposure. Now we're definitely seeing this impact of the co-exposure that is more than the individual contribution of either exposure by itself. And we saw similar results for cardiovascular and respiratory mortality. Some samples or some results indicated here where you can see that the extremes to both was more than the individual components of exposure. And we also observed larger effects among older individuals, here being defined as age 75 or above, where this co-exposure effect for those that were 75 or above was 36%, as opposed to those that were less than 75 was 8.5. So much bigger effect in this more vulnerable population. So we published this earlier this year. It had a nice editorial that went with it. And the other thing is Larry and I and the team and the lead author, Mustafish Rahman, who's our postdoc, or the postdoc on the team, did a lot of work to talk to reporters about what it is that we found. And so we did a lot of effort around getting it picked up. We got a press release. We did a lot of media interviews, radio interviews, and you can see this altmetric score indicates that it was almost 200 news stories from a variety of different outlets. And then we also wrote, a couple of the co-authors and I also wrote a piece in The Conversation, which helps translate the scientific findings to a broader community, or broader audience, which then also can get picked up in media outlets. So I mentioned we also looked at whether these relationships were different among different individuals with different social economic status or social environmental burden. And so we used a couple of metrics to look at this. We had the Cal and Virus Screen score, which is a measure of social environmental burden. So it takes some social factors as well as environmental factors, a social deprivation index. And we also, so these are neighborhood level. And we also had individual level education as reported in the death certificate. So there's potential concerns for bias there, but that's what we can work with for individual level as a proxy for their individual level SES, social economic status. And really what we observed, and I just have one figure here kind of showing this, we actually really didn't see very, very consistent differences in this effect of extreme co-exposure by these factors, by social economic status or social environmental burden. They're similar across different groups. And so this is something that we delved into a bit and talked about quite a bit. And something in the literature that's shown is that sometimes these neighborhood factors don't really capture what the individual in themselves is experiencing. So it could be that there's something going on, but these factors weren't able to really pick it up. Or it could also be that these extremes are just so bad that everyone is being affected quite severely. And then we evaluated associations with suicide and homicide mortality. And so here we used a similar approach as what I just talked about. You can see the number of deaths during this time frame. One thing to note here is we looked at exposure as a continuous exposure, so linear response as opposed to the extremes. And that's because we actually saw these, see here in these graphs, these trends of with increasing exposure, increasing mortality. So on the left here is suicide mortality, on the right is homicide mortality. And so we evaluated it using this framework instead. And we did the same thing where we looked at, same day versus prior day. You can see some of those here. We have daily maximum temperature and minimum temperature similar to before. And so really what we observed is that with higher temperatures, there was increased odds of both deaths due to suicide and deaths due to homicide. We didn't actually observe any relationship with air pollution, which has been seen in some studies previously, but we really saw the effect with temperature here. And so this is particularly concerning because we see it across the entire range of temperature, not just the extremes. And as we know that this is a vulnerable population already to begin with, and then with increasing exposure, thinking about the public health implications of this work. That's the last one for me. So pass it back to Larry.
So the work that Erika just presented to you provides the context for what we're looking at with respect to health equity. As you can see, there's certain groups that are at greater risk by virtue of age. We also were interested in seeing if there were certain groups at greater risk by virtue of place of residence. There are certain areas within Los Angeles and throughout the country that are considered to be urban heat islands or defined as urban heat islands. And typically they represent neighborhoods or communities where the average temperature on a daily basis is significantly higher than the temperature of surrounding areas. So that within Los Angeles, for example, there are certain parts of the city that tend to get warmer during days of high temperature and also tend to be more exposed to air pollution by virtue of proximity to industrial plants, to freeways where there's a lot of carbon emissions from vehicular traffic, and fewer resources to cope with the increased vulnerability or increased risk. So we decided in conjunction with the epidemiologic and quantitative data that Erika and the team were collecting to collect some qualitative data as well, to capture the knowledge, attitudes, and behaviors of residents of low-income urban neighborhoods that are defined as urban heat islands, to see whether or not the quantitative experience that we were uncovering through the population level data resonated with the qualitative experience of residents of these communities. So we wanted to explore the following questions. How do they respond to heat waves and days of poor air quality? Like what kinds of adaptive behaviors or strategies do they employ during these events? What resources do they have to cope with days and prolonged days of extreme heat? And the extent to which, by virtue of a lack of resources, they were more vulnerable, or the extent to which they were able to compensate for the lack of resources by greater resilience. We wanted to know how vulnerability and resilience were related to one another. Were they merely, opposites of one another or opposite ways of defining the same activity, or two completely different constructs? And then finally, we wanted to know the response in terms of health outcomes. Now, we weren't collecting epidemiologic data in these. We were collecting self-reported information about experiences during events like this and what the consequences were. We had the good fortune of collaborating with the USC Neighborhood Academic Initiative, a program that is designed to prepare middle school students and high school students in low-income neighborhoods for success in applying to college and succeeding in college. They enroll each year about 1,000 middle and high school students. We had the opportunity to meet with parents of students attending the Fauché Learning Center, which is on the other side of Exposition Park, El Sereno Middle School, which is closer to the USC Health Sciences Complex, and Nightingale Middle School on Figueroa, who were participating in this. We ended up interviewing 40 parents or caregivers of these students. Almost all of them, 39 of them were women, one was a male. The average age about 42. It was distributed, the majority were Latinx, 2/3 of them, but about less than a quarter were Asian, predominantly Cantonese-speaking Chinese parents. About 62% of them had a high school education or less, and most of them rented their homes rather than own them. to the extent that we were able to use information based on an urban heat index developed by the California EPA office, we found that two particular neighborhoods in which these participants lived, one had an average temperature of 4 degrees Celsius above the average for the city of LA. 55% lived in communities that were considered to be impervious surfaces. In other words, very little green space, predominantly asphalt, with only 3% tree cover and 99% of being a minority population. The second neighborhood was 1.7 degrees Celsius above the average, 79%, so a much larger percent of concrete, less green space. In fact, only 7.4% tree cover and 96%. So an urban heat island, as you can see, has very little green space, predominantly non-white minorities or non-white populations. And in the average income, household income in both of these communities was about $49,000. We conducted a series of semi-structured interviews in 3 languages because we had many of our participants who are monolingual Spanish or monolingual Chinese. So we were fortunate enough to have graduate students in social work who were bilingual, who were able to interview them in their native languages. And we asked them questions about their past experiences with days of poor air quality and prolonged heat, their knowledge of how to prepare for such events, their attitudes towards climate change in general, as it manifested itself in heat waves and air pollution, and the adaptive behaviors and resources that they had to cope with these events, and finally, self-reported health impacts of exposure to these events. We analyzed this data using thematic content analysis to uncover different themes related to these kinds of events. So we've done 2 studies. We've done 2 studies so far based on this data. The first focused entirely on the heat waves. And the most common response to heat waves was staying indoors. So 60% were these got,
I don't know, 60% staying indoors because it's in the light.
yeah, but for some reason that got reversed. Oh, here we go. Oh, I see, that's why. So the first is the air pollution study. The most common behavior was staying indoors in response to a day of poor air quality, followed by wearing face masks. A little over a third reported that. Keeping doors and windows closed when indoors, and drinking plenty of liquids, usually as a response to dry throats, which were experienced during days of high levels of air pollution or wildfire smoke. The most widely used resources available to these participants were apps on their cell phones, which enabled them to check daily air quality index to figure out how they should prepare students to send off to school or not send them off to school for that matter. 75% of them reported some type of health problem or physical discomfort due to days of air quality. This included sore throat or swollen eyes, allergies, and asthma or trouble breathing. But interestingly, people also reported mental health systems. So 1 in 5 reported feeling depressed. 30% reported feeling anxious during days of poor air quality, much of which was attributed to having to stay indoors and feeling a little confined or claustrophobic. Almost all of the participants asserted that days of poor air quality were likely to increase in frequency as well as intensity. Much of that attributed to exposure to or greater numbers of cars on the road, a greater industrial pollution, and a lack of concern for the environment, which related to limited recycling and greater littering or disposal of unwanted items. But almost all of them agreed that these events were likely to have severe impacts, particularly on individuals who were susceptible to respiratory illnesses, to older adults and to children. In the heat wave study, we also found, interestingly, that while 2/3 of our participants had air conditioning at home, many of those with air conditioning limited use due primarily to the high cost of electricity or occasionally to power outages during areas of periods of high use. 1/3 of participants lacked air conditioning entirely. About 80% of them had advance notice of a heat wave, much of which they got through the news and social media. Other resources that they utilized were social networks, family, friends, neighbors who checked on people during the heat wave to make certain that they were in good health and doing okay. Having access to green space, not necessarily within their neighborhood, but going elsewhere, either in Los Angeles or outside of LA, to be in areas that were somewhat cooler because of the availability of trees and other forms of green space. The adaptation behaviors were in some respects what you would have expected. Everyone, for example, reported the importance of staying hydrated during heat waves, remaining indoors or going to cooler location, wearing lighter clothing, reducing energy usage. But there were also some interesting variations to that. So, for example, many of the Chinese immigrant parents who participated reported consuming special foods, particularly soups and teas, as a way of staying cool during a heat wave. In addition to non-cooked items like melons, ice cream, and raw fruits and vegetables. Again, as was the case with the air pollution, almost all the participants asserted that heat waves were likely to increase in frequency and intensity, much of which they attributed to climate change specifically, with adverse health effects for children, the elderly, those who worked predominantly outdoors, and those who had pre-existing chronic conditions. So on the basis of this, we were able to generate a conceptual framework, which is rooted in the socio-ecologic model, which is fairly well known both within social work and public health. But we call this the 4R model, dealing with the risk associated with these events, the response in terms of the adaptive behaviors, the resources available in a community or within a household to adapt to these events, and then finally the results manifested in physical and mental health outcomes. Another thing that we learned is that resilience and vulnerability, as I said, are not necessarily the same thing, but rather manifest itself as two distinct constructs, so that in these communities, we saw not only vulnerability in terms of high levels of physical and mental health outcomes, limited resources, but high levels of resilience as well in the utilization of what resources were available, and the limited severity of many of the health outcomes that were reported. So that of the 40, while the majority of people reported some physical or mental health outcome, only 2 people sought medical attention for heat-related conditions, and only 5 people sought medical attention or medication usage for any of the air pollution-related events. So one of the benefits of collaborating like this and in fulfillment of the intent of the Strategic Directions and Research Award has been a number of spin-offs that have occurred as a result of our activities. The first has to do with a study that 2 doctoral students, one in public health and one here in social work, have been engaged in looking at the association between climate change and migration from Northern Central America, specifically El Salvador, Honduras, and Guatemala, and the mental health consequences of both climate change and the migration process. Second study that Erika is going to tell you a little bit about is a study of electric vehicle use and health disparities that we're keeping our fingers crossed will lead to an R01 study for the next 5 years. The Pacific Rim Climate and Health Equity Network that some of our faculty have been involved with. And then hopefully we'll learn by the 15th, a Center for Climate Health Equity that will be funded through the National Institutes of Health as well. So I'm going to tell you first about the first one. The intention really, as you know, there's been a great deal of interest in the southern US border and the flow of immigrants from Central America, either southern Mexico or, as I said, northern Central America. And that has generated interest, not just because of the desire to seek asylum, but greater focus on what they're fleeing from and what can be done about it. So a great deal of attention has been given to poverty, to gang violence, to political instability, but much of that in turn has been fueled through climate change. So the intent of this particular study was to conduct a narrative review, which is one of the first steps to the process of conducting systematic reviews on the link between the 3 particular stages of this process. One, how the climate in this part of the world known as the dry corridor has been changing over time, how that has impacted migration, not just internally from rural to urban areas, but also internationally to Mexico and the United States. And then finally, the mental health outcomes identified in this population. Among the things that this study has found is that in the last 2 to 3 decades, the region has been impacted by severe and prolonged drought, intense tropical storms, and increasing temperatures, which has resulted in millions of people who have been suffering from food insecurity and hunger on the one hand, and reduced economic productivity in rural areas on the other, simply because crops aren't able to be successfully produced as they were in the past. This has in turn led to substantial migration, as I said, from rural areas to urban areas, and then from both rural and urban areas up to Mexico and the United States. The group of migrants, as you probably heard through the media, experience considerable dangers and stressors along the way, including violence by gangs, by local government officials, which is also exacerbated pre-existing or pre-migration levels of stress, anxiety, and trauma. So consequently, the few studies that have been conducted on this population have reported increased levels of stress disorders, depression, and anxiety. So I'll give it back to Erika to talk about the electric vehicle study.
Yeah, so this is new research that I've worked with my colleague, Dr. Sandy Eckel, as well as Jill Johnston and Lori Palinkas, and then also our community collaborator from the SELA Collaborative, which is the Southeast Los Angeles Collaborative, Dr. Wilma Franco. So this was submitted as an NIH R01 this past summer. It was reviewed last month and we got a 7th percentile. So we're hoping that means that we will get funding on it, which will be great. And just to kind of provide some context for a rationale here. So we know that there's this transition to electric vehicles. Driving in the parking lot this morning, I saw a lot of Teslas. And this is an important tool for climate change mitigation. And it's projected to have considerable co-benefits for public health, especially through the reduction of tailpipe emissions. Right, this is a key source of harmful air pollution. There's still, of course, considerations of non-tailpipe emissions. At least we don't have tailpipe here. And California in particular is a leader in EV adoption for the United States, as demonstrated by the graphs that are included here. So our question was, are there health and air quality co-benefits that are already detectable, observable with current relatively low levels of EV adoption? And so we did some preliminary analysis looking at this. So this is currently under review, please do not share. And you can see on the first graph on the left, it's showing that there's this increasing number, increasing number of electric vehicles that are being registered, and this is by zip code across this time frame. The colors indicate the educational attainment, the average educational attainment by zip code, and you can see that those with higher, more green educational attainment are increasing the number of electric vehicles much more rapidly than those zip codes with lower, more purple educational attainment. So this is a big concern around this adoption gap, which threatens the equitable distribution of potential co-benefits. The graph in the middle here is showing the relationship between electric vehicles and a particular type of air pollution, nitrogen dioxide, adoption over time. And so we have this trend with decreasing air pollution as the number of electric vehicles have been increasing over time. And then the just last graph here is looking at the relationship with asthma emergency department visits. And so we see this relationship with over time, as a zip code has increased in the number of electric vehicles, the rates of asthma ED visits has gone down. This is again the relationship with that increasing number of electric vehicles. So based on this, we framed our grants, this idea of the co-benefits of the EV transition using observed data as opposed to projections, which is predominantly what has been done previously. So working with Larry, we came up with this sequential qualitative, qualitative mixed methods design, and it has really continued community engagement. We have a couple of different ways that we're doing that to develop a conceptual framework of EV adoption and to really expand the quantitative analyses findings, which is kind of what we've done with our work that we presented earlier. So we have a first aim around community focus groups, some analysis of neighborhood and contextual factor to understand how EV adoption is playing out in California, and particularly in Los Angeles area, estimating this relationship with air pollution, and then estimating these relationships with different respiratory health outcomes, specifically COPD and asthma. And in both of these, contextualizing it with neighborhood factors, other factors that might modify these relationships that we observe.
So a third spinoff that has emerged as a result of this collaboration has been the development of a network across the Pacific region to address the issues of health equity that are associated with climate change. This actually began with as a result of the Social Work Grand Challenge to create social responses to a changing environment. And a collaboration involving Susan Kemp, formerly of the University of Washington, who's now at the University of Auckland, Megan O'Donnell, who's a psychologist based at the University of Melbourne in Australia, and Michael Spencer and David Takeuchi, who are also in Seattle at the University of Washington School of Social Work. The intention really was to create an opportunity to provide assistance to both small island developing states, low and middle income countries throughout the Pacific, as well as indigenous communities in high income countries like the US, Canada, Australia, and New Zealand, to provide support in not just understanding the impacts of climate change on health and wellness, but responding effectively to those impacts and potentially to mitigate them as well. So our mission is to address the health disparities associated with global climate change by translating research into policy and practice. So a focus on the implementation of evidence-based solutions to many of the problems that have been identified, and building capacity for translational research. So not merely having educators and researchers like ourselves from high-income countries initiate studies and conduct them, but to provide the training necessary to enable researchers, practitioners, and policymakers throughout the Pacific region that currently lack this capacity to do so in the future. Currently, we have about 40 members, many of them academics from institutions in the United States, Australia, New Zealand, and the Philippines, as well as non-academic organizations like the International Organization of Migration, which is affiliated with the United Nations, the Asian Disaster Preparedness Center based in Thailand, the California Disaster Preparedness, California Office of Health Hazards in Sacramento, and a provincial entity in Papua New Guinea, the province of New Ireland. The approach that we're using is referred to as community partnered participatory research. It's very much like community-based participatory research, but it involves an equal partnership between academics and community members, which means equal access to funding and equal involvement in all phases of the project, from conducting a needs assessment, identification of potential solutions, implementation, and evaluation. Some examples of the work that have been engaged by Parish members even prior to the formation of the network. As many of you may recall, in 2013, in the aftermath of Typhoon Haiyan, colleagues from the School of Social Work, including Vivian Villaverde, Annalisa Enrile, Marlene Wong, went to the Philippines to provide assistance in responding to this typhoon, which killed tens of thousands of individuals and resulted in a displacement of over 4 million residents in the Philippines. And the objective of this effort was to provide instruction in evidence-based approaches to addressing the mental health concerns, addressing child welfare and social trafficking issues as well. Marlene and Vivian subsequently returned to the Philippines to provide training to educators and Filipino Peace Corps, which are first responders, not just in the Philippines, but elsewhere throughout the Pacific Rim. A second effort has been led by our colleagues in Australia to develop a stepped care approach to addressing mental health concerns. So they developed the skills for life adjustment and resilience, which is part of the WHO MGAP series of interventions, which can be delivered by non-mental health professionals and groups. They've pilot tested it successfully in response to a typhoon in the island nation of Tuvalu and the Australian bushfires. And a third effort has been that of the International Organization of Migration to provide training to practitioners and policymakers throughout the Pacific region in response to the COVID pandemic. Finally, is, as I said, a new initiative called the Center for Climate Health Equity, funded through the Alliance for Community Engagement and Climate Health, which is sponsored by NIH with the National Heart, Lung, and Blood Institute as the lead agency. It's going to be led by 4 MPIs, myself, Ben Springate, who's based in New Orleans at LSU Health Sciences Center, and then our colleagues in Population Public Health Sciences, Chinita Hughes-Halbert, and Rob McConnell. Our goal is pretty much like the Strategic Direction and Research Award, to leverage our expertise in climate and environmental health, community engaged research on health equity and implementation science, to reduce the burden of climate change and climate related health disparities, and accomplishing that by developing a multidisciplinary translational teams, which can not only identify risk factors, but also assist communities in selecting potentially successful responses to those risks as well. We have 5 specific aims. The first, to provide training and technical support for community engaged research. In other words, instruction in the community partnered participatory research modules that have been used throughout Los Angeles and New Orleans, but adding a component dealing with climate health, assessing the multi-level impact of current climate-induced stressors, such as hurricanes and heat waves, flooding in Louisiana, and heat waves and wildfires in California. Assessing community knowledge, attitudes, and behavior. So expanding the qualitative portion to understanding urban-rural differences and differences between communities in California and Louisiana. Identifying feasible and acceptable community engaged strategies for reducing the health disparities associated with climate change. And then building new partnerships by identifying experts in the area who can also provide assistance in conducting community engaged research. Our conceptual framework is also based on the social determinants of health, with partnerships between social work, public health at USC and the LSU School of Medicine, and a number of community organizations and government entities in California and Louisiana. Our first phase, which we hope will begin January 3rd of next year, will take place in Louisiana at the request of the funding agency. The second phase will occur 2 years after that and focus on California. So I'll end by acknowledging our collaborators, both in social work, population public health sciences, and the Viterbi School of Engineering. And the few minutes we have left, take questions.
Applause. And then it might be easier to see folks online if you stop share. And then we can, if anybody wants to shout out a question, that's good. And we might see some hands raised online. Anyone want to shout out a question? Yes.
I'm just curious, in terms of the EV,
Mhm.
I was just wondering what other variables have you looked at in terms of potential relationship with the lowered asthma visits? So is it, are there any potential other variables, because California engages in climate change behaviors differently than other states. So I was just wondering.
Yeah, so the specific analysis that was shown there looks at the rates over time within each zip code. And so we're really taking into account the trend of the change in the number of EVs that are registered in that zip code in that, I think it's about a 7-year time frame, and then relating it to the change in ED visits reported for patients at that same zip code during that same time frame. So what's really nice, and I'll say Dr. Sandy Eckel, who's I think on the call there, ran the analysis. So kudos to her for doing this and thinking about the framework for it. It's really nice because all of those things that are the same within everyone in the zip code are controlled for, because you're comparing the zip code to itself over time. And then you're comparing those trends among all the zip codes then in California. And in that analysis, it's a little bit of a preliminary analysis, but we do control for some factors like trying to get at temporal trends, because there might just be decreases in asthma related e-visits over time during this time period. So we try to take into account trends over the year. We try to take into account information around the SDS variables that might differ from zip codes, which might also relate to both the change of the ED visits over time, as well as a change in the number of electric vehicles over time as well. But I think there's a lot there that we want to be careful about how we're trying to decouple these things, because it is complicated. But I think the framework of comparing a zip code to itself within a relatively short time frame of a decade, 15 years, there might be some differences in your population, but they're probably going to be less than the differences between populations of zip codes.
Thank you. I have a question sort of in follow-up to that regarding, the availability or the accessibility of electric vehicles and the infrastructure in the neighborhoods that are most affected by the air pollution. And it just seems to me to beg for subsidies so that, everybody has an equal opportunity to access this cleaner technology. And I just wondered if you had some comments on that.
Yeah, so that's really there's a lot of research on these potential barriers, like the cost of electric vehicles, ability to charge them, especially if you're not a homeowner or in a single family home, such like if you're in an apartment building, where are you going to charge it? And so that's really why I think this coupling between the qualitative methodology and the quantitative methodology is really, really helpful, because we can look at the literature, we can look at these surveys that have asked these questions before, we can look at data, but why don't we go to these communities and talk to them? Because we have some knowns, but we have some things that we do not know. And so the perception around it, and there are economical incentives for installing EV charging in your home, for buying EVs themselves, but even just the knowledge and perception around them, the concern around, especially like electric vehicles, they've been around for like a little bit more than a decade at this point. So what's new is there's also a used EV market that we didn't really have before. And how does that translate to changes of costs initially, then also concerns around maintenance, especially thinking about battery warranties, 10 years, and thinking about incentives for this new kind of structure if there is a used EV market. And I think that's really great. Again, talking to the community, we also have an advisory board that includes other stakeholders in the area, including government agencies that are interested in these exact things. Where do we place public EV charging to get a more holistic perception of these, and hopefully then answer the questions that are out there to inform better policies, hopefully reduce the impact or to increase equitable distribution of this. At the same time, we also have to be a little cautious, because we know electric vehicles, they reduce tailpipe emissions, but they tend to be heavier than traditional cars. Yeah, I think it depends on the model, but they can be like 25% heavier. And so what that means, you're going to get more road dust. The brake wear, especially with regenerative braking. And so this is what we refer to as non-tailpipe. So other pollutions related to traffic, but that does not come out of a tailpipe. Tailpipe is the end, are still of concern, and potentially even of a greater concern in electric vehicles. And of course, there's the more holistic thinking about the manufacture of vehicles and whatnot. So there's an analogy to gasoline and oil extraction that also has a big history as well. So
thank you. Excellent.
You're probably also aware of the fact that California is committed to, ending the sale of gas-powered vehicles by
Yes.
2035. So this is very timely.
Absolutely.
Hi, thank you very much for this. I teach the equity and diversity course here at the School of Social Work, and I'm particularly intrigued by this because, sometimes I think of electric vehicles and upcoming technology, et cetera, as a wonderful new resource, but it also, the flip side of that is that it might create another way by which the inequities in our communities are further exacerbated. And by that, I mean, in certain communities, people are going to be buying these cars. Why? Because they have the capacity, they have the education, they have the income, et cetera. And to what extent, and then I'm thinking about what you were saying, Larry, of the interviews that were done with these parents and Fauché and Nightingale and El Sereno, and I'm very familiar with the El Sereno Nightingale neighborhoods, and Nightingale is right next to the 110 freeway, right? But I was thinking that even though you interviewed these parents, very few of them thought about seeking out medical care for any issues that might have been affected by the poor quality of air or the sense of heat deserts, etc. And that makes me wonder about to what extent these communities see these issues as issues of equity or inequity. You know what I mean? To what extent do they see that what's happening in their neighborhoods are a social justice issue, an environmental justice issue? The parents themselves.
They don't use the language, but they're very aware of the fact that they're at a disadvantage. So, for example, many of those, when we talked about days of poor air quality, made reference to the proximity to freeways and proximity to factories. When we asked people, so what, are you concerned about these? They were all concerned. They're, in fact, I think only 2 people said there was no problem with air pollution, and only 2 people said there was no problem with it. They didn't notice the heat being any more. In fact, our Chinese, many of whom came from Guangdong province in southeastern China, said this is nothing compared to what we've used to experience. But they do make reference to the lack of green space, that they are at a disadvantage there. The fact that, traveling to the beach is not particularly an option because of, limited access to transportation and distance. And the fact that, they think it's ironic that whenever there's a heat wave, they're more likely to suffer the effects of blackouts due to, power disruptions than, say, residents of Beverly Hills. So there is a very strong sense of disadvantage, a very strong perception of disadvantage. But at the same time, there's a strong sense of resilience as well. We make do with what we have. In fact, when I asked about health problems requiring, I am very worried about my children was a common refrain. But when we asked about, my children stay healthy because I keep them indoors. So that, they actively attempt to do things in the face of that kind of discrimination. Excuse me.
Yeah, now, I just wondered to what extent they see social institutions as the entities that might help address these kinds of disparities for themselves. I hear you talking about the things that they do themselves for their children and for their families. But to what extent in these communities, people who live in these neighborhoods and communities perceive, for example, the Department of Parks and Rec or other types of social institutions as the ones which should be embracing them because of the inequities in SES, et cetera, the lack of resources for green spaces.
Well, perhaps because it is a biased sample, coming from the Neighborhood Academic Initiative, the one institution they do express and not necessarily resentment, but concern are the schools. So concern about, children being forced to exercise or do their PE classes outdoors on days of poor air quality or, days of excessive heat. Wanting some better connection to schools to help better prepare students to cope with these events. We heard a lot of that.
Any more questions from the Zoom?
I had a quick maybe question, comment. If I understood correctly, I think the data you collected for your analysis, I think I remembered you saying that it was monitored outside, but you also said that there was 60% of the folks who stayed indoors and 1/3 of the participants lacked AC. So how do you account for that lack of information as to who used air conditioning and what effect would that have had on mortality? How does that affect your conclusions?
So the 60% people reporting stayed indoors during days of poor air quality. The air conditioning is used, but usually they just use the fan. They don't put it on the cool cycle. They're more concerned about circulating indoor air on a day of poor air quality. A larger number of them have fans, either ceiling fans or movable fans. But even though 2/3 of people had air conditioning, a number of them, decided not to use air conditioning or use it very sparingly because of the cost in terms of the utility bills. There were a few people who expressed concerns about being in a cool indoor environment, going to a very warm outdoor environment, especially our Chinese participants who figured that would actually create health disparities because it would increase, it would result in physiological changes that would be disruptive. So for that reason, they neglected to keep indoor spaces cool. Staying indoors on days of warm temperatures may not seem like a very adaptive form when it's hot indoors as well. But then again, when the availability of outdoor space that is relatively cool is limited, it's a form of adaptation that they feel they have their only recourse to.
And I will say for the epidemiologic analysis, this is a concern and potential limitation because we're, working with tens of thousands of individuals. I think for all cause mortality across the entire time frame is like 1.5 million deaths. So it's a lot of numbers when you use these administrative databases. And so the question around like, well, were they indoors or outdoors, right? Were they in their home? Were they at work? Were they at a park? These are questions, these are data we do not have. And so we're making some assumptions about what heat we're relating to our outcome of concern. And so there might be some, what we refer to as measurement error or misclassification as to, what the level of exposure truly was for that individual and what we're assigning them. But even with that, we're still seeing really strong relationships between these extreme heat exposures and mortality. And the same thing actually goes with air pollution, because air pollution can be quite different outdoors versus indoors, depending on the specific pollutant. It also depends on your building type and your window types, and it gets really complicated. But these are definitely things that we are aware of, and concerns can be potential limitations. So I think areas that we can try to do better to reduce our misclassification, reduce potential for bias in these analyses to get better estimates are also key and important. So thank you, Jane, for bringing that up.
Thank you. Thank you.
And I have one question regarding the analyses, or if I can remember correctly from the beginning of the talk, and you shared the association between morbidity, mortality, and the estimates of the particulate matter and of heat. And that the risk of mortality increased when there was both air pollution and heat. And I saw that the confidence intervals were quite a bit wider for the two variables combined rather than looking at each as an independent predictor, if you will. And I wondered, you know, was it sort of the usual thing that might be driving that? Was there anything in particular that would account for that wider confidence interval when it was a matter of both heat and particulate matter? Maybe it was just a smaller number of observations.
Yes, so it definitely would be a smaller number of
Yeah.
observations, because if you can imagine, I didn't put the numbers in here, but it's in the paper, in the publication. If you're thinking about the top 5% hottest days and top 5% polluted days,
Right.
so you're gonna get about 5% of each of all the
Yeah.
individuals will be in each of those overall. But if you think about the co-occurrence of them, it's not gonna be 5%, right? It's gonna be some probably number smaller than that. I can't remember off the top of my head what it was, but it is lower. So you're picking up very well. That part of it is a sample size issue that's just leading to wider confidence intervals. And in many of them, including the all-cause mortality, the confidence intervals, although wide, were still statistically significant, at least,
Yes.
you know, some p-value of 0.05,
Yes.
for better or for worse. And that's interesting too, because, you know, I think like with the lag one day was a 21% increase excess risk.
Mhm.
But if you look at the confidence intervals, and people often look at the lower bound, like, oh, well, you know, it could have been as low as with the 95% confidence with appropriate interpretation, you know, 3% or whatever it was. But if you look at the other extreme,
Right.
it is the same thing, just on the flip side of how high it could have been.
I think it was like 32.4 times or something.
Yeah, so it's, you know, it's a range, and I think there's definitely more work that could be done to try to refine that. We do have a lot of numbers already. Like we have a high end, we have more years, but I think the important piece is that we see this effect. It's not surprising that now if you have two things going on, two things that are going to impact mortality, it's going to be greater than the sum of its parts. And what can we do to reduce mortality, reduce other health burdens that might occur on those days? And it's interesting because one of the things we talked about a lot, especially when doing the media reports, where, you know, we have, and Larry picked this up in the focus groups, you know, there's all these alerts about your air quality index. You have apps for it, right? You get information about heat waves through the news. Well, can we do something where we're going to have a high air quality day or like a bad air quality day and high heat? So folks know, especially on this day, do take behavioral changes to reduce your specific vulnerability, especially if you are in a sensitive population. And I think that's one strategy that can be used potentially going forward.
Well, thank you for that response, and thank you so much for your presentation. And it doesn't matter that we're a bit over time. It probably matters to you. We held you for a long period of time. So if there are no other questions, then I want to thank you both again, and thank you so much for attending the second colloquium in our School of Social Work. Have a good day. Yay.